Hey guys, just wanted to catch up and just check in with you and see how things are going. Um, it is February, the month of cardiovascular health, and it's an important month for me, um, or at least when it comes to cardiovascular health, this is an important part of health. Um, and in talking about the cardiovascular health month, I wanted to talk about cholesterol testing, conventional evaluation versus a functional medicine evaluation. This is important because my father had a heart attack at age 52, and he is a healthy guy. He doesn't smoke. He's not obese. He actually is pretty active. He works a pretty tough job as a contractor, pretty strong physically, works long days. And so, not at all the risk factor that we would expect, or the person who we would have expected to have a heart attack. His conventional cholesterol labs were all normal, and he ends up getting a heart attack at age 52. So this is really important to me, and one reason why I started delving into functional medicine, aside from my own health issues. But functional medicine, the reason why I like our approach is because we actually look at those blind sides that can get you in trouble. There are definitely more labs that should be taken into consideration, especially if they're known risk factors. But 75% of heart attacks have no health risk factors and normal cholesterol tests. And so it is important, if we're going to be true in preventing cardiovascular disease, which is the number one killer in America, is that we actually look at the blind sides, which include other specialized functional tests. And these tests are lipoproteins, which we look at the size and the amount of the lipoprotein. We look at the type of LDH or LDL, sorry, and HDL. And then we look at other inflammatory markers, because when it comes down to it, the blind side of cardiovascular disease is looking for inflammation. So when it comes to LDL, size matters. And so this is probably one time that I'll tell you where fluffy and large is actually good. So when you have a fluffy large LDL, that's what we call an ApoA type of cholesterol, and it's actually good. It's so large that it's not going to get stuck into a leaky artery. The problem is the smaller LDL sizes, which is an ApoB type. It's the bad cholesterol, or the bad LDL, because it's just small enough to get stuck in a leaky artery wall. And when it gets stuck in there, it'll start triggering oxidation and inflammation. And that's actually the backbone and the stickiness that contributes, the inflammation that contributes to the plaque that starts building up. So let's compare what those numbers mean, at least with an example of a tale of two patients. Joe, he's a 62-year-old male, history of smoking for 2 years in his teenage years, but he's since quit over 40 years ago, so it's a long time ago. He's healthy otherwise. He exercises pretty regularly and eats well. He's concerned because his father and his grandfather had heart attacks at his age, and he recently did a cholesterol test, and his LDL was 148. And his question is, Doc, should I be more concerned about this, and should I be on a statin medication? Let's compare him to Jack, who is a 64-year-old male, healthy. He doesn't smoke. Doesn't have any family history. He's actually fairly healthy and exercises frequently, and in pretty decent shape. And his LDL is also 148. So if knowing those histories, who has the highest cardiovascular risk factors? We would assume that maybe Joe, because he smoked and he has a family history, that he would be the highest risk factor if we can, consider that in a conventional way. But it's hard to say. The reality is when you're looking at LDLs, I can't really tell risk factors because I know there's so many blind sides of inflammation. So when somebody asks me that question, am I at risk for a cardiovascular event? My answer would be, I need to look at your inflammatory markers and have a more extensive, thorough cardiovascular workup. And so I did that with these gentlemen. And Joe, who we think has a higher risk factor, his LDL, when we looked at his sizes and type, his LDL is mostly an ApoA type, which means it's large and fluffy. So it has a less chance of getting stuck in the arteries. Plus his HSCRP is normal. So he really doesn't have, at this point in time, any signs that make me think it is an excessive risk for a cardiovascular event. Jack, on the other hand, who we think is he's generally healthy, actually healthier than most people his age, but his LDL is mostly an ApoB type, which is small, and his HSCRP is in that mid range at 1.2, which doesn't totally get him out of the woods in terms of risk factors. And so, what about this LDL? How does your LDL change sizes, ApoA versus ApoB? Well, it's at the decision of the liver that tells the body if it's going to have a predominance of an LDL A type or LDL ApoB type. And the messages that go to the liver that tells us that'll actually produce an ApoA versus an ApoB is triggered by things like your sugar and insulin resistance, high triglycerides that are coming from really saturated fats and high cholesterol and high carbohydrate diets, local inflammation, maybe the inflammation's coming from your gut, or stress, cortisol coming from just crazy life stressors, specific hormones. Excessive estrogens can cause a bump in your LDL. Toxins, there's specific toxins that are associated with cholesterol issues. These are the triggers that within the liver produce oxidative stress, and that's actually what's going to contribute to the small LDL being produced. And so the liver makes that choice, or at least in the settings of all those triggers, will push inflammation, which we can measure in the blood as CRP. It's also contributing to other changes in your blood vessels, essentially leading to stiffness in the blood vessels. But more importantly, inflammation leads to the plaque formation. It becomes sticky, so now the plaque can start building up. So this picture shows that this small LDL the small LDL can squeeze through the artery, the leaky sides of the artery, and then it gets oxidized. And then that oxidation stimulates inflammation. And so all these inflammatory markers come in, and it's actually just the nice sticky base that just makes all this inflammation build up, and that essentially results in a plaque formation. When you get this plaque formation, you can imagine, look, you just don't have a lot of movement. You don't have a lot of patent artery for blood to flow through. And so as you build that plaque, it gets harder and harder for oxygen to pass through. And so that obstruction is what leads to the sensations of heart pain that would lead to a heart attack. This is a great picture depicting the spectrum of inflammation. I like it because it tells you, or at least it's easy for me to share with patients as I'm explaining to them the level of inflammation that's going on. And so as you build up plaque, you start seeing changes in the blood in terms of the factors in the lab values in your blood. So if you just start building up a little bit of plaque, you'll start seeing your HSCRP bumping up. That's sort of what we saw in Jack, who had that mildly elevated HSCRP. It showed that he probably has some mild plaque formation already. As healthy as he is, he still had that plaque. You could check other factors like MMP or MPO, or this specific factor called LPPLA2. And this tells you that you're really getting into trouble with unstable plaque. You're at the verge of getting you set up for a heart attack. It's important to know these because then I can gauge where people are in the spectrum of inflammation. This is also helpful for me to decide for people high risk. Definitely, if any of my patients have any significant LPPLA2, for sure, if you're sitting in this unstable plaque situation, you need to be on a statin. We need to have all the types of support that we need to help prevent a heart attack, because that's just a heart attack waiting to happen. So we can quantify, knowing levels of inflammation, where people may be sitting with risk factors. There's another separate risk factor called homocysteine. This is a bit more controversial in terms of it's being a true risk factor, but there's an idea that if you have too much of this homocysteine, it tends to be a large molecule. And because it's large, as it's cruising through your arteries, it can bang up on your arteries and actually cause damage just by sheer direct trauma. And then if you start damaging that artery, you could see where you could start, start having inflammation coming in, and then you could start building up plaque just off of the trauma that you sort of initiated with this homocysteine. This is a separate risk factor that's related to a genetic risk factor called MTHFR. And when you have that risk factor of MTHFR, you tend to not process your homocysteine, right? You don't recycle it very well. And so your homocysteine starts to raise in your blood. This is my dad's risk factor. When I caught up with him and started realizing these risk factors, his homocysteine was really quite high. But it's nice because now that I know that is his risk factor, I can really focus in on methylation for him, getting this homocysteine levels down. And I can use the homocysteine as a marker for him now. But it's also then the risk factor for myself. I can watch my homocysteines and make sure I'm staying out of the clear from that risk factor. There are newer risk factors that are involved with inflammation. We're finding out there's a connection between gut microbiome, basically the bugs in our gut affecting the risk of your heart disease. And this was the issue of Jack. Remember, he was like really, athletic, no risk factors, LDL of 148, and his LDL of 148 was coming from his gut. And it so turns out that he was so healthy that he was really pushing a lot of keto, where he had a really high, really disproportional amount of protein. It was very good protein, grass-fed, very good choices of protein, specifically a larger amount of the red meat component of his diet because it was mostly keto and less of the carbohydrates. And this is the problem with people trying to be healthy and being really extreme with some diets. If you have the right kind of food content, at least in the setting of red meat, and then you have the right kind of bugs, those bugs will basically process that red meat and make this intermediate metabolite called TMAO. Or actually, it's TMA, and then it's changed in the liver to TMAO. And this is a factor then that also contributes to cardiovascular disease and inflammation in your arteries. So Jack, who is generally healthy, was pushing TMAO because he was being really extreme with his keto dieting. And so for him, it took a lot, but I had to convince him that he needed to take in a little bit more carbohydrates, and then to consider dealing with this bacterial issue. And so the TMAO, there's data now that shows this is probably why probiotics are beneficial in the setting of decreasing your cardiovascular risks. It probably has to do with this TMAO and also all the other inflammatory issues that may be triggered in the gut lining that then affect the liver, making small ApoB lipoproteins. But there are some specific bacteria that are supportive of decreasing the TMAO. And then there's some other natural herbs like berberines and resveratrols that can be helpful. And so as it comes to inflammation, inflammation truly is the blind side of cardiovascular disease. And this is where functional medicine looks. Conventional medicine has a habit of just looking up on the top of known risk factors and typical cholesterol tests. But as a functional doc, we look deeper into these unknown areas that are just under the surface that are related to inflammation. And so our cardiovascular workup is a bit more detailed, looking at the type of LDL, the level of inflammation, maybe some of these other risk factors contributing to cardiovascular risks, the spectrum of inflammation we can check in blood work, and even a handful of other risk factors outside of the knowns that are related to hormones, thyroid, diabetes, and toxins. And so it's obvious there's conventional treatments that we know about: stop smoking, exercise, weight loss, control diabetes, avoid excess alcohol, try not to eat the typical American standard diet with trans fats. Eggs are actually okay. And then typically on our conventional treatments, we'll use statins for severe risks, especially with cardiovascular disease and diabetes. In our functional plans, however, we think about inflammation in that blind side. So we're actually looking at anti-inflammatory supports. So we like the Mediterranean diet because it's low in inflammation and it has high anti-inflammatory supports like omega fish oils. We may consider probiotics or at least dealing with better gut health. And at least in the case of homocysteine, if you need support with methylation, we'll consider those. There are some more innovative types of treatments that are being thought out. There's a specific treatment called hydrogen gas, molecular hydrogen gas, which basically helps at the level of oxidative stress. So in the cardiovascular disease, or at least in that chronic disease model, there's a lot of oxidative stress. So molecular hydrogen, which is not an FDA-approved treatment plan, but it could be something that in the future may be helpful to help those with cardiovascular disease. I like to use it in conjunction with a lot of really important other anti-inflammatory supports. And this is just a sample of a case. I'm just going to call her Sue. Sue had lots of inflammatory issues, heartburn, esophagitis, and came to me with an LDL 198. When we looked at that, it was concerning because it was elevated ApoB patterns and HSCRPs were 2.3. She wasn't excited about starting a statin at that point. She had some specific nutritional deficiencies, so we had a place to start. So we dealt with that from a lifestyle standpoint, nutritional standpoint, diet standpoint, exercise standpoint. But then we trialed a little bit of hydrogen gas for 6 weeks, and interestingly, her LDL went from 198 to 103, and she also decreased her ApoB, and her HSCRP went down to 1.8. So it wasn't probably just the hydrogen gas, but I think the combinations were very helpful because it addressed the important root cause of cardiovascular disease and the root cause of how our body's making that bad, or at least, the higher risk ApoB as it relates to the liver. And so the 21st century medicine, we shouldn't be blinded. I know conventional insurances don't like to cover these types of tests, but there's different ways we can get to that. I definitely order these for my clients. There's direct-to-consumer labs that people can use if they don't have access to functional doc, and you can even order them on your own. And so be open to learning new lessons, even if they contradict the lessons you learned yesterday. And these are the lessons of cardiovascular disease. Inflammation is the important trigger. So 21st medicine is functional like. It shouldn't be confined to the 20th century bureaucracy that's related to the rules and regulations of health insurances. The illiterates of the 21st century won't be those who can't read and write, but those who can't learn and unlearn and relearn. So this is a wonderful quote that really does reflect what our knowledge base is now about cardiovascular health. It truly is an inflammatory disease. And so we must look past those blind sides and actually look into those blind sides. So functional medicine is an avenue or at least a place where we can look deeper into your risk factors of inflammation. So if you're interested, there's my contact information. If you have not had an opportunity to look into these risk factors that might be sitting unseen in the blind side. So again, I'm Dr. Angie Martinez with Root Cause Medicine. Contact me if you'd like to look at these factors and and establish care to look into this further. Otherwise, this is all educational. So, please, take this information to your primary care doc if you are considering making any changes in your chronic care. Before making any of those changes, please discuss with your primary care doc. Have a good night.